be part of the group here. And um, it's I apologize for miscommunication with the dates, and that's why we had to change it. And I'm sorry I'm a few minutes late. It's noon right now in San Antonio, and we were for running a little late. Again, thank you for the invitation. And what I'd like to do now is share my screen so you can, let's see, let's go right here. I'm going to share my screen and let me know if you can see it.
Yes, we do.
Yes, we
Yeah,
can.
okay, excellent. So let's get started here. Let me make this a little smaller. Let's put that here. Let's go presents. Okay. Okay, so yeah, so today I'm going to talk about electronic global clinical evaluation for competency assessment, calibration, and outcomes assessments. And as was mentioned before, I'm a dentist, and it's great to be part of the efforts by the medical profession to improve assessments in Saudi Arabia. This is a project that has a universal appeal, so it could apply to all healthcare professions. So it could apply to the medical, dental, and the nursing. We developed a method of evaluating that is currently being used by a nursing school in the United States. And a lot of the fundamentals that I'm going to talk about were actually developed in medicine. And as you're going to see, the medical profession and evaluations are always ahead of all of the other professions. So we learn from the medical side how they evaluate, and we try to adopt and customize to dentistry. I tried to make this a little more medical related. My talk to the dentals, to the Saudi Dentals Society was more geared towards how the curriculum is structured in dentistry. So I'll try to highlight some. I'm not an expert in medical education, but I can draw some conclusions and commonalities between dentistry and medicine. So let's get started. As was mentioned, I'm originally Egyptian. أنا بتكلم عربي. So I was a dental student here in San Antonio. This is my class, So in general, the dental and medical school in San Antonio, we have a dental medical nursing. It's called a health science center. And the medical classes are 250 students, and the dental are a little smaller, usually 100. I know in the Middle East, the classes are a lot bigger. This is me in a simulation lab, and this is important to talk about because I know, and then the medical side and the dental side, there's always a simulation component where you start working on a mannequin, or you start examining a mock patient. Here in the medical school, for example, they'll have cameras in an exam room, and they want to see how you interact with it's not a true patient, it's like a simulation, and to see how you interact before you go to clinic. So that's what we call the simulation lab, and that's in both in the dental and the medical curriculum. And so this is my evaluation form. When I was assessed, this is back in 2012, 9 years ago, and it was done on paper. So the director of the rotation, or in the medical side, it's called a clerkship, or I'm not sure what it would be called in Saudi Arabia, but in the US, they call it a clerkship or a rotation. And, the director would have a piece of paper like this, and he would evaluate you based on competencies. And I'll talk a little more about that. And at the end, you'll get this piece of paper at the end of the semester or at the end of the month, and it'll tell you how you are doing. I always had a problem with this because for the whole month, I had no idea how I was doing, right? And you get this at the end of the month, and then you'll see a remark, for example, on September 1st, your filling was not acceptable. But I'm getting this evaluation on September 30th. And then in my head, I'm thinking, I wish I would have known this 30 days ago, because since then I've done 5 fillings and I didn't really get good feedback. So I didn't improve. And that's, a fundamental of our assessment philosophy is we want real-time evaluation. Because if you're seeing a patient, I want you to know that day, written and verbal, how I feel you did, so that way you can improve. We have a strong presence of Saudi Arabian residents at our school. These are some of the best people I worked with. They're all faculty now in different schools in Saudi, whether it's in Riyadh and Jeddah, and I miss these guys. And I applaud, the government of Saudi Arabia for sending a lot of their students, whether dental or medical, to different parts of the world to learn. And in my opinion, Saudi Arabia is probably one of the most advanced countries in terms of education, and how they're implementing the philosophies from Europe and the US. So that's a great effort. So I started teaching as a resident. So when I was a resident, I started getting interested in teaching. So this was me as a resident, 2014. These are some of our residents, very diverse group. We went to do some dental care for the football team. And when I talk football, I'm not talking like soccer. Here they call it, so it's American football, where they wear the helmets. So we go and do some mouth guards for them. It's exciting. This is our class. This is the end of the year picture. When COVID started, we had to stand far away from each other, everyone wearing masks, but right now it's a lot better here. I'm a big basketball fan. So, here, for those of you who watch basketball, San Antonio Spurs is our team. They used to be really good. They're not anymore. And this was a big game, and you can actually find me in the stands. That's me. So I also follow, Saudi Arabian soccer, El Hilal, Al Ittihad, and that's fun too. And this is, me with some of my Saudi friends. So now let's talk about this. This is actually a 2-hour seminar. So I'll probably, do an hour. I can rush through it, and then we can, come back maybe at a different time and talk about some other things. But we're gonna go pretty quick. If you have questions, we can pause. If we don't get through the whole thing, that's okay. We can do another session if the group is interested. Okay, so let's get started. As we know, that the biggest problem in health education is, how do we know when a student, and you can put for medical, dental, or whatever here, is competent? Or in other words, how do we know they are ready to practice independently? Okay. So this is a picture of me with my student for graduation. And how do we know that the student is actually capable of going in the real world and working by themselves? So if you look at this graph here, and this looks at experience over time, and this is their performance. When you have a medical student, in their first, their second, and third year, they're not that good, and they don't have experience, and their performance, they need a lot of supervision, and they need a lot of help from faculty, right? And then they start getting better when they have strong didactic background, more clinical experience through the rotations or the clerkships. I'll elaborate on that, until they reach a point. It's this point that we want to capture, and we want to know, okay, are you capable of working independently? Are you going to do a good job or not? So this point here is called competency. And for the longest time, we weren't able to identify when these students are ready. So this is just a background of our school. This is our dental building. This is actually our medical building right here. So, we try to keep them close so patients can go back and forth. This is what our clinic looks like. This is a room. So for you in the medical field, each student has an exam room. This is like an exam room. This is what it looks like, the student clinic. So a student will be working on a patient, and me as faculty, I work with the students. I observe them every day. So as a director, I observe, and the key to good assessment is constant observation. Constant observation, immediate feedback, and it has to be close observation. So we try to keep the group small, like 15 students maybe, and 3 to 4 faculty. So your ratio is 1 faculty to 4 or 5 students. That way you can, work with a small group. I know in the Middle East, this sometimes is not possible because the classes are huge. And these are all the students. So in the medical and the dental side, we follow the same concept. Me as a faculty, I meet the students from their first year. So let's say Ahmed Sabbah comes in as a first year medical student. I meet him and I know him. And then each group of students are assigned under a faculty. So that way I can observe them over 4 years. Me and a group of faculty. It's not just me. So these students are first year, second year, third year, and fourth year. And I've seen them from the first year and how they've developed. And that way, constant observation over a long period of time will show you the progress of these students. So, the dental degree and the medical degree, it's 4 years after the Bachelor of Science. So it's a doctorate degree, not like in the Middle East. And then in the 4 years, whether it's medical or dental, you have 2 years of classes and pre-clinic. So you do your simulation, and then you have 2 years of clinical training. This is a universal, dental or medical. Okay, 2 years of clinical training. So let's talk about the medical curriculum, and this is the curriculum right now in NYU, New York University. And it's pretty much the same for most schools. So in the first year, they'll do a lot of didactics. And I'm not sure if the schools in Saudi Arabia have adopted this, but this is called system-based learning, right? So instead of them doing a class in biochemistry, a class in physiology, a class in histology, it's now called system-based. Even the dental school does the same thing. So they'll go to cardio and they'll do everything with the heart. They'll look at the anatomy, they'll look at the histology, they'll look at the physiology, and so on. So the first 2 years system-based, it's more integrated, and it makes more sense. It makes it easier for the students to understand everything about the heart instead of it being so segmented. And then in their second year, they start doing some kind of clinical rotation. Now there are all these articles that say, the earlier, the better you introduce them to clinic. So what we do in the dental side is in their first year, they start coming to clinic, but just to shadow. They just observe, so they're introduced to clinic a lot earlier. So if you want to improve your curriculum and clinical experience, you introduce the students earlier. And the medical school is doing the same thing here in San Antonio. Introduce them early. This is just an overall overview. So in their second year, they do some clinical clerkships, and I'll talk about what a clerkship is according to the American Association of Medical Education. And then they have more clerkships right here. And then they start taking their boards. They could do electives. And then in the fourth year is when, they start doing comprehensive care. So there are core clerkships. These are the clerkships that are mandatory according to the board, the medical board. And it's same thing in dentistry. And in these clerkships, that's when you define if someone is clinically competent. Each clerkship has a director, and the director works with these students over, let's say, a few months, a few weeks. It depends on the clerkship, but usually it's a few months, and they observe them daily. And you're supposed to document their progress. And as you can expect, at the beginning, they don't do that well. They don't know for what's going on. And as you observe them for a longer period of time, they start getting better and better until they achieve what's called competency. Okay. So this is a US medical curriculum. Now, so let's talk about medical clerkships. And by definition, it's full immersion in clinical practice. So we're done with the didactics now, we're in clinical practice. And it happens under supervision. So you'll have a director, The core rotations in the United States are family medicine, internal medicine, gynecology, obstetrics, pedo, and surgery. So these are the core ones. These are the ones that are just everyone has to do. Then you can go into different ones based on your interest. Again, I'm not a physician. I don't really know a lot of details about, if you want to go into dermatology, how is the selection process? That's, for an expert in the medical education, but it's just to give you an overall view based on the articles in the American Association of Medical Education. They want 800 minutes per credit hour of clinical interaction. And that equates to about 5 to 6 hours a day. 5 to 6 hours a day in the third and fourth year of patient care, okay? So there's heavy emphasis on patient care, third and fourth year. And then you have the clerkship directors, as I said, that supervise this whole thing. And it's on the directors who work directly with the residents and the students that they determine competency, right? So let's talk about some definitions. Okay, so let's talk about competency. So for what is competency? Competency is, let me move this. Okay. So competency is a complex behavior. I'm not going to read this. There are 3 things you need to accomplish to be competent. So your student or the resident has to be independent. Okay, so that's the first thing. They have to perform with a degree of quality, so high quality. So you have to be independent and good. And then the third thing, and this is key for competency from the medical and the dental field, you have to be able to self-evaluate. So these are the 3 things we want to accomplish for someone to be, you know what, you're competent and you are ready to go to independent practice. So it's also not about acquisition of knowledge. And I think this is a fundamental flaw we have in the Middle East, is that a lot of our students feel that they just have to memorize. And then in Arabic, they say, in Egypt, when, I went to school in Egypt, and they say that el walad dahih, like he's just like memorizes everything, doesn't understand. However, we want them to be able to create new knowledge. Okay, so these are really the 4 things that you need to know. Independent, they have to be independent, high quality, and then they have to be able to self-evaluate, and they have to think critically, acquire new knowledge. Okay, and these are the stages of competency. So when you look through the literature, the medical literature, these are the stages. And if you remember the graph I showed you at the beginning, you have the novice or the beginner who, needs a lot of help. And then you have a beginner, and then you have someone who's competent. And that's what we're trying to get. We're trying to get these guys who are competent, who are independent, they can self-assess, and so on. We're not looking for proficient or experts. That comes later in life. So, I don't consider myself an expert at this point either. So expertise requires thousands of hours in a certain field. Okay, so now that we talked about competency, let's go and talk about the kind of assessments that we use in the world, really. So there's a formative assessment and a summative assessment. So let's talk about a formative assessment. So the formative assessment is an evaluation where I'm assessing the development of a student and I'm giving him feedback. I'm not giving him a grade, okay? So I'm giving them written and verbal feedback. There's no grade. So what ends up happening is the students don't take it very seriously. They're like, whatever. It's not going to be a big deal if I don't do well because it doesn't impact my grade. I don't know how it is in Saudi Arabia, but now in the US, a lot of medical and dental schools are moving to pass-fail. So pass-fail. There's no imtiaz and gayed gidden and that stuff anymore. Some schools are still with a grade, and San Antonio still has a grade, but a lot of schools are going to pass-fail, and then the students don't take it seriously, okay? These are for more frequent. An example is daily observation. These are the formative assessments. Okay, so what is a summative assessment? A summative assessment is when you give them a grade, okay? And usually it's giving at the end of a training, And the problem with, so some people think, you know what, I'm just gonna give a summative assessment for everything. But when you do a summative assessment, it actually causes a lot of stress on the students. And um, and then what ends up happening is, at least here in the US, the students get to pick the case they want to take their test on. And I don't know if it's like that in the medical, in the Saudi medical education, but in dentistry, for example, they will come to me and say, for Dr. Sabbah, I want to take a test today, and I'm going to take it on this case. So they end up picking a very easy case, right? There are criteria for the case, but they pick the easiest case possible. And then I'm giving them a grade on a case that's easy, not necessarily a real life case. And then that grade is supposed to tell if they're competent or not. It doesn't make sense because they picked an easy case. So that's why the idea of competency can't be based on one test. It has to be a comprehensive overview or a global overview of the student, and it has to involve both formative and summative together. Cherry picking is just a term meaning that they pick an easy case. I want an easy case because I want to get a good grade, right? And then validity, there are a lot of articles, a lot of studies that show that it's not very valid when you only do summative assessments. This is an article actually from the nursing the literature. Okay, so these are a bunch of nurses in the UK. So this is worldwide. You know, we're not only talking about the US. And I just want you to focus on their conclusion here. And they say that mentors want clinic to be positive experience for the students. And it leads the mentors to give higher grades than what the student actually deserves. It is very rare that a nursing student fails in their clinical practice. And I run into that problem, you know. I see the student, I've been with them for 2 months, I don't want them to feel bad. So if their entire rotation is based on one grade, even though I feel they're not ready, I'll just pass them because I don't want to destroy them, right? So that's why it's important to just do comprehensive over time assessment where your entire grade is not based on one test or a couple of summative tests. Okay, so let's talk about calibration. I'm going to stop in a few minutes to give you guys, you know, time to ask questions about what I talked about. But let's just talk about calibration. So what is calibration? And that is a huge topic here in the United States. For a medical or a dental school to get accreditation, you have to show that all of your faculty are calibrated and they are grading to the same level. And you know, you're gonna have this anywhere you go, where there's a faculty that's very easy, faculty that's kind of in between, faculty that's extremely hard. And the students will always go to the easy faculty. And for that reason, you have to show that you have some kind of session or some kind of metric or measurement where you have all the faculty at the same level, right? So calibration by definition is to standardize the measuring instrument. So you have to have a faculty that's called the gold standard. So for example, in our clinic, we have 5 faculty. We know that one of them is an accurate grader. And the reason he's accurate is he understands the standards, or what they called the rubrics, right? And he understands the rubrics. And then we compare everyone to this one gold standard. So it's important for you to find a gold standard in your clerkship, in your rotation, etc. And then the goal is to increase inter-rater and intra-rater agreements. So what is inter-rater agreement? It's 2 raters or 2 professors who grade the same performance. So inter-rater, let's say me and you, and we are grading for one student. Me and you need to be about 90% close to each other, right? Or within one standard deviation. If I give him 100% and you give him 90, that's acceptable. If I give 100 and you give like 50, now we know that one of us is wrong. Now, who's wrong? You compare to the gold standard. So for a lot of our summative assessments, okay, these are the assessments that are a test case. You're working on a real patient now. We have 2 graders, and the 2 graders have to be in agreement. Now, if we look at the 2 graders and they're off, we bring in a 3rd grader, and the 3rd grader is the tiebreaker, okay? Now the other one you need to know about is intra-rater agreements. So what is intra-rater? It's the same rater grading same performance. So it's me, and I'm grading student A, student B, student C. I need to grade them all at the same level. I can be easier on this student versus that student. And you see that a lot when you're grading a 3rd-year student and a 4th-year student. So what happens is I'm the same grader, and I look at a 3rd-year student who is less experienced. And in my head, I'm thinking, this student is less experienced. He made a mistake because he doesn't know. I'm gonna give him a B. And then a 4th-year student comes and he does the same mistake that the 3rd-year student did, and I give him a C. That is intra-rater, it's a disagreement. The 3rd-year student, even though he's less experienced, should have gotten a C. You have to grade everyone with the same standards, whether it's a 3rd or a 4th year, because my expectation is, and I'll go into detail into that. My expectation is that the 3rd-year student is less experienced, and I expect him to be about a C. And then what I want to see, that curve that I showed you at the beginning. So in their 3rd year, I'm expecting them to be about a C or a high C or a B. And then as they go to the 4th year, I'm expecting them to be at a B or an A. So that's intra-rater. And then we talked about the rubrics, which are the definitions. So these are what the rubrics look like. You have to develop a rubrics for everything you do. So this is what it looks like in dental education. You know, patient education, you'll have different clinical domains. I'll show you the domains for the medical field. And if the student does this, I'm giving him an excellent. If he needs faculty help, I'm giving him a different grade. And then there are critical errors. These are errors that if you do, you get a 0 there, and you have to identify for each domain what a critical error is. It's just unacceptable. Absolutely no way. Okay. So I'm not gonna get into this. I already explained this, that you have to have a gold standard and then you compare to the gold standard. You have inter-rater and intra-rater. Inter-rater is that 2 professors grade about the same. Intra-rater is me as a professor, I grade students the same. So I can't be biased, and I can't look at their stage in medical school and say, I'm gonna give you a higher grade because you're a dental, because you're a 3rd year. So this is how schools traditionally evaluate competency and are you ready to graduate or not. I think this was the most common, and this was a study done in all dental schools back in, I think, 2000. So let's see, this was done in 2008. So this is a 13-year-old study. And they asked the dental schools around the country, how do you evaluate if a student is ready to graduate? Essentially, are you competent or not? Pass all courses, complete all the requirements, complete all the rotations, or complete the last year of dental school satisfactorily with consistent observation from your faculty on a daily basis, or you have to pass a bunch of exams, or the department, it's up to the department, you know. And the vast majority, 67%, say A, you have to pass all the courses. However, now we're noticing that passing courses with a C is unacceptable. I mean, do we want to graduate people who in their last 6 months of their medical or dental education are still getting a C? And the answer is no. Okay, so even if they have a C grade, and it could happen because in their 1st, their 2nd, and their 3rd year, they just did a bad job. But what I want to see is the last 6 months of their dental or medical school. I want to see A in the last 6 months. And I say 6 months, at least, and right before they graduate, I want to see that they're independent, they can self-evaluate, and they're doing high quality. I don't care about their cumulative grade can be a C, but towards the end, I'm expecting everyone to be at an A, because that's who we want treating our patients, treating me and you. If they're unable to show that towards the end they're excellent, then they need to come back and we need to do something. We need to do remediation. So these are the different way we assess students in medicine and dentistry. You could do for multiple choice exams, daily evaluation in the clinic, clinical competency exam, student self-evaluation, and longitudinal evaluation in the clinic. And back in 2008, only 4% of schools were doing that. And this is really the fundamental now. Longitudinal evaluation in the clinic, I'm evaluating you over time. And I want to see at the end that you're doing a good job. I'm going to talk about Miller. He's a physician, that came up with a lot of these ideas. We'll talk about that in a second. But this is from Miller's article, and he was a physician. So this is from the medical literature. It's the collective wisdom of faculty who have consistent opportunities to observe and interact with the student is essential and core of performance assessment. So what does that mean? You want the students to be with the same professor as much as possible because it's the opinion of the doctor, of the faculty, and their interaction with them over time. Like I said, the longitudinal evaluation, that is the core for performance assessment. It's not paper, it's not me putting together some numbers. A lot of this is subjective, but we try to make it as objective as possible. And it is extremely important to not eliminate the faculty and say, no, the numbers are what matter. It's the opinion of the faculty at the end that makes a difference. But you have to make sure that your faculty are calibrated. You don't want a person who's just very hard to make the decision. And you need to identify these faculty, and you have to go talk to them and say, you know what, you're just extremely difficult. You're very hard. A lot of people are failing. They're avoiding you. And, we have to be on the same page. Why is it important to evaluate competency? I mean, this is data for dental schools. I know in the Middle East, education is almost free. But, in the US, they graduate from dental school with an average loan of $260,000. So I want them to be good so they can make money outside. And I want them to feel prepared. So, this is just a survey by the Dental Society asking students who are going to graduate, how prepared do you feel? And, they don't feel prepared. Like 45% of the students don't feel prepared in these domains, and digital dentistry, special care. And, this is concerning because now you're going in the real world and you don't feel prepared. Now, how are you going to work on these patients? And again, this is accreditation stuff. If you want to be accredited by the US, and I know some dental schools already in Saudi Arabia are accredited by the US, and that's huge. I'm not sure if any of the medical schools are going that route, or are they accredited already, but huge emphasis on assessments, huge. So if you look at this is assessments. From 2012 to 2019, 50 schools were assessed for accreditation, a grand total of 50 in the US. 23 of the 50 had a deficiency in assessments. So you can say that, you can tell assessments is the biggest question mark in education in general, right? So what's the common complaints of clinical assessment? You have calibration problems. Okay, now I have all this data. How do I analyze it? A lot of the dental schools and medical schools in the US still use paper. The students don't get written feedback. Maybe I'll talk to them. A lot of times the students are scared of the professor, so they're not going to approach them. So you have to find a way to give them the feedback, regardless of their personality. Obviously, faculty are very busy, so very time consuming. Grade inflation. So what does that mean? It means that we give grades higher than we should because we don't want to destroy the students. And that's back to the nursing school article that I showed you. And then very subjective. Okay, so I'm going to stop right here. This is actually the first part of the seminar and we're already out of time. So let me stop right here, and I could take questions for this first part if you guys want. So let's take a few minutes here. Any questions?
Yes, please, participants, if you have any questions, please feel free to ask, raise your hand, or you can write in chat box. I think we should continue then.
Okay. So let's talk about the Miller Pyramid. I think this is very relevant for medical education. So Miller was a physician, came up with this Miller Pyramid in 1990. And if you haven't read the article, very informative. And this is really the core of competency assessment. So there are four levels of the Miller Pyramid. It's know how, show how, and does. So what you want to evaluate is, does the student know the information? So this is the didactic component in the first and second year. So you can give them for multiple choice exams. So no. So this is how you evaluate their knowledge. So for multiple choice exam, short answer, essay, oral exam. I know. So these are ways to evaluate, do they know the information? Now that they know the information, do they know how to apply it? So know how. So do they know how to apply it? So for example, and then the third component is show how. Now that you know how to apply it, can you show me how to apply it? And this is where you have the lab and the simulation exercises. So the students are observed, whether on camera, whether directly by faculty. Can you work in a simulation environment? Once they show you how, okay, now I want you to do it on a real patient, right? So this is the does part of the Miller Pyramid. So these are how you can evaluate directly. So direct observation, peer assessment, you ask their classmates, how are they doing with you? Self-assessments and multi-source feedback. This is 360-degree where you ask everyone. So you ask the faculty, you ask the coworkers, you ask the assistants, you ask the front desk, you ask the patient, you ask everyone how this provider is doing. So that's called 360 multifactorial feedback. So this is the top of the Miller Pyramid. So again, 4 layers: know how, show how, does. Now, when you look at the top of the pyramid right here, does, there are 3 corners of it. You want to evaluate their performance, you want to evaluate their knowledge, and you want them to be able to self-assess, right? So how do you evaluate performance? We talked about this. Sustained over time. You want to linear observation. For example, we have 2,000 hours of clinic in our curriculum. So that's way I can see them for 2,000 hours. And you're not supposed to do one test and that determines, are you going to be a doctor or not? It should be a linear observation over time. Avoid cherry picking, and it should be the daily observation plus an exam. Let's talk real quick about clinical domains. So these are the domains. You have to divide your curriculum into domains, how you're going to assess them. These are the domains in the medical field. These are 6 general competency domains: patient care, medical knowledge, professionalism, interpersonal communication, patient-based learning, and system-based practice. And these are the different methods that you can evaluate them. I talked about the multi-source feedback, direct observation, live or video. So these are the different, the 6 general competencies in medical education. So after you identify your competencies, and we identified them, these are our competencies. So, you don't have to worry about our dental competencies, but so once you identify the competencies that are relevant to your school based on, accreditation documents from the Middle East, from Europe, from the US, you have to come up with the rubrics. So these are the definitions. So critical thinking, What is critical thinking? What is satisfactory? Well, so define each one of them. So that's what we did earlier. About 4 years ago, we defined everything. And then you just want to identify your domains. And so again, we're talking about the top of the Miller pyramid, and that's does, right? And then so you have the knowledge, and we already talked about, how you're going to evaluate the performance. Then you want them to self-reflect. And self-reflection and self-assessment should be done daily. And it should be done all the time. And you ask the students, how do you evaluate your process? I have a whole section about how you should do it, but I'm just introducing the idea that they have to self-evaluate. In the US, we have them evaluate by writing a paragraph, how they feel about how they did. That's called reflection, and they give themselves a grade. A grade is called self-assessment. So they give themselves, what would you give yourself, an A or B or a C? I give myself a B. And what you'll always find is the students give themselves a higher grade when they don't get feedback. But when you give them feedback, now they have better understanding of their performance and they'll be more accurate. And we did a study on that as well. I could show you the results of that study. And then knowledge, you just want them again to be able to apply the knowledge that they created and create new knowledge. So they have to be able to problem solve, critical thinking, new knowledge, right? This is a new concept in dentistry, but it's been around in medicine, called EPA. EPA now is a better way of assessing clinical practice. And it's very important for you to understand this. It stands for Entrustable Professional Activity, EPA. This was started in medicine, early 2010. Now it's, in dentistry. But essentially what you want is, you want them to be in a working environment and you want to observe them working in the clinic. That's what entrustable professional activity means. Or it's called another component called workplace-based assessment. So I'm assessing them in the clinic. I don't care about your grades in the oral exam. I don't care about your grades for multiple choice. That's all good, but can you do it in the clinic? So this is in the medical field here. These are 3 frameworks for assessment in the medical field. Okay, so this is from a journal, a dental medical journal, sorry. You have the analytic, the synthetic, and the developmental framework. So let's talk about synthetic. And these are where you have your domains, and this is more in the didactic. When you look at the synthetic, I'm looking into tasks, clinical tasks, and this is where the EPAs are, okay? Can you do this in the clinic? Now, once I got you through the didactic, which is the analytic framework, and I got you through the synthetic, can you do it in the clinic? This is more complex patient care. Now, I got you competent. Now it goes back to the article I showed you, where there's competent, then there's an expert, and then, there's a professional and then an expert. And this is more after they graduate, when they're in their residency or their internship. This is where they are here, the developmental. This is a list of EPAs for medical schools. EPA is, again, clinical assessment. Can you gather history and perform a physical exam? Can you prioritize differential diagnosis following a clinical encounter? Can you recommend and interpret common diagnostic and screening tests? Enter and discuss orders, document the clinical encounter, provide an oral presentation, form clinical questions and find evidence in the literature, give or receive patient handover, collaborate with other members in the team. That's not just you. Can you work with others? Can you recognize a patient needs urgent care? Can you obtain informed consent? Can you perform general procedures? Can you identify system failures? So these are the EPAs that you need to have in the medical field. Okay. So I think I'm going to stop right there. So these are the 2 things we talked about. Now there's an assessment program we created. I'm just going to show you what it is. It's essentially a software that we use to to assess the students daily. You can do this in medicine or dentistry. You write down their procedure, and this is how we capture our data quick. These are our EPAs: critical thinking, knowledge, assessment. Can you do anesthesia? Can you do fillings? Can you do, surgery for you? Can you do an exam? Can you talk to the patient? Are you professional? Do you have ethics? How is your time management? And you give them a grade. So you give them a grade 4, 3, 2, 5, whatever. And you do this every day. And then you accumulate all this data and you draw a curve. And then you know, is the student progressing or not? Consistent evaluation. So this is, our solution. It's being used in dentistry and medicine and nursing, and it just very customizable. So you come up with your EPAs and you put them in there. If you want it pass fail, if you want A, B, C, D, any grade you want. So this is what the dashboard will look like, right? These are all the students, and these are the procedures I looked at, and I graded them. And you're able to generate comprehensive report. Now, it's all about big data. They call it big data, data analytics. I want the data, I want the data. So this is how we're able to provide the data. So this is a report, comprehensive report, tells you how many times they were graded. And this is their average. This is my average. This is the average of all the students. And now I know, okay, you have a 3.0 on a 4.0 scale. So you're doing okay. You have a 3.5, you're doing better. And that's how you compare. Consistent evaluation. Let me show you one last thing, and then we can take some questions here. Okay, so we talked about the reporting. We asked our faculty, do they like it? And they like it. Even though it's electronic, it's on an app, it's on a phone. And then let me show you something cool in calibration real quick. So then this is how we calibrate our faculty, okay? So now that we have all this data, I know who graded who. Like the app captures, Dr. Sabbah graded this student, and these were the grades. So now we have all of our faculty. These are all the professors. And this is how many times they graded each of the EPAs. So this is an EPA called critical thinking. And then I can know how they compare to each other. So if they're green, they're within 90% of each other. If they're yellow, 80%. So for example, this professor is, is close. All these guys are within each other. But when you have it red, that means these guys are just very hard graders. So for example, you'll find a red arrow right here. This professor is 42% different than the rest of us. So then I can go to this professor and I tell her, why are you so difficult? You're on your own. We need to work together because you don't understand the criteria. And how do I have this data? Because I'm grading daily. I'm grading every day. So I have the faculty evaluation grades and I have the students. So you're able to look at the whole thing. I'm gonna stop right here. And I know this was a lot of stuff. It's just a big topic. So if you have any questions, I'd be more than happy to take them right now.
Thank you very much, Dr. Ahmed Sabbah. So participants, if you have any question, please feel free to ask. You can unmute and can ask and raise your hand. Any question?
If there are no questions, my email's there. If anyone is want to ask later, that's also okay. My email is in the thread that you guys got. So
yes, Dr. Hamza. Yes, Dr. Hamza.
Assalamu alaikum wa rahmatullahi wa barakatuh, Dr. Ahmed Sabbah. Really, we enjoyed your talk, even though you are talking from the dental, but there's a lot of similarity. Yes, we totally agree, especially when we come to the assessment part. There is and even in our colleges, we do communicate with our dental colleagues, and there are some of the dental colleagues will be with us, that usually when they graduate, they are really competent and they start working alone. But the difference here, and I don't know how it's in the state, that when our medical students, they graduate, they are not that competent that to work independently. And I have seen many places, not only in Saudi Arabia. So that's the one thing. And why it is like that? And is it your extensive teaching and assessment? And as you said, that it is a very, looks like it is a very huge pragmatic assessment where you collected a lot of data and you're looking for the feedback and so on. That's the one area. Then the second questions, which I was thinking, that you initially said that pass-fail, yes, there are a lot of schools have moved to the pass-fail. And that, I think, the system, which in Saudi Arabia, this is, we are bound to that, that is not yet, still we are grading 60% is a pass and less than 60% is a fail. And so we need that comment from your expertise. Thank you very much.
Yeah, thank you for the comments and the compliment and the question. So let me address the second question first. So in terms of pass fail, even though a lot of the schools have gone to pass fail, you know, you still need a detailed grade, because I want to see how good you are. So passing in the US means that you're competent. So you only pass if you're competent. So let's say you have a C and you know you fail to show sustained excellence over time, then you'll fail. However, I think the majority of the dental schools are not pass fail. You know, they still have a grade. They're moving in that direction. For me, as a director of a residency, it's very hard for me to take students from a pass fail school because I don't know their grade. But if you ask each school, can you give me with a detailed percentage, they will. So they have the data. So I'm not advocating that you get rid of, you know, the grades completely, but you should have it somewhere in your curriculum that if you get an A or B, that's pass. Okay, but I still have your percentage documented somewhere. And then, yeah, for us in our school, if you have a C, that's not a pass. You fail. So that's unacceptable. A or B is the only way you can graduate. In terms of your first question about why are they not competent when they graduate, I mean, it has to go back to their experience. Are they getting enough patient experience? Are they getting the feedback? And in the medical education, they have to go through a residency in the US. So when they're done with the 4 years of medical school, you expect them to be competent in the core competencies that I talked about. Can they take an evaluation? Can they do an exam? So on. Then when they go into the residency, then they're now a specialty. You expect them to be competent in different competencies, you know, different EPAs. So it just goes back to you have to give them the clinical experience. And as you see, the US medical schools advocate 6 hours a day of patient interaction, clinical experience. So maybe you need to look at clinical experience. Are they getting enough? Is it not enough? Could we expand it, and so on? I hope I answered your question.
Thank you. Yes, Dr. Ali.
Good evening in our part of the world, but good afternoon at your side, Dr. Ahmed. I really enjoyed every moment of your talk. I have a problem. I'm a program director for a residency, so it's post-grad, but there's a problem with the the interdependent raters. Like we have a hawk and we have a dove. And sometimes it's just like poor resident. It's just like, I'm not sure, should I just ignore because the rubric, it's very difficult to get people to get back to it. Sometimes the time is quite concise. Maybe for the futures, we're going to tell them about the rubrics and change the mind of these assessors. But in these circumstances, I would like your advice. Should I just discard the assessment of the hawk, and maybe poor resident should pass and look at the dove? Or what should I do in this circumstance, especially in the summative assessment? Thank you very much.
Thank you so much for the question. This is an excellent question. I'm also a program director, so we use this app in the residency. Okay, so what we do and how we fight this issue is this app, or now in 2021, all the assessments should be electronic. Really, there's no reason to have it on paper because it goes to Excel. You could do a lot with it, right? So the apps are on the phone, and then the rubric is in the app. It's in the phone. Okay, so let me show you. Let me see. Where's my presentation? Right here. Let me go back to where the rubric is. So we don't expect that the faculty have it memorized. It's impossible. And you're right, there is the hawk and the dove. So you see right here in the app, this is critical thinking is one of our domains. When the professor clicks on one of these, see right here, this is the rubric. So when you click 3, the rubric comes up. So I want the grader to see the rubric in their face. That's number one. I don't want you to memorize it. I just want you to read it. And what we do is we have 5 faculty in the residency, and we have 18 residents for the whole year. So we accumulate the rates every day. So let's say today I'm working with resident A. Tomorrow he's working with another professor. The day after, another professor. He's working with all these different people. So over time, I have the grades from everyone. And you're right. If there is the hawk, and this hawk is grading harder than everyone else, I'll just take his grade out. And then I need to talk. I need to calibrate him and show him. Like a lot of these graders don't know that they're so hard. So I'll show him, these are the 4 faculty, and this is our average, a B. Your average is C. You're a lot harder. So we're going to take your data out for this year, but for next year, we want you to improve. Does that answer your question?
Yes, it does indeed. Thank you very much. That's a very bright, ideas about showing this rubrics, and we do use a similar program, but I think giving a suggestion and add the rubrics might be of a help. Thank you very much.
Thank you. Thank you.
Thank you very much. Dr. Ahmad, there is one question in chat box that how did you develop this rubric?
The rubric is developed by all the faculty. Okay, so we came up with our EPAs or our domains. So we came up with them, and we did it in an Excel sheet. And then we just said, let's say patient exam. What is excellent? What do you feel is excellent? You see, it goes back to the 3 things I talked about. They have to be independent. They got a comprehensive exam, and so on. And then what is acceptable? What is the minimum? So the minimum is, they needed a little bit of help, but not really. And then what is unacceptable? They missed glaring issues. So it's a collective help. For you to start this process, if you don't have the rubric, you just need to look through the literature. And there is a lot of published for rubrics on medical education. You don't have to reinvent it, So that's where we started, yeah.
Any other question, participants, before we end session?
Actually, I have a comment, Shazia, if you allow me.
Yes, please.
I think Dr. Ahmed is spreading the culture of rubrics itself. I think we need a session on that, just addressing the issue of rubrics, how important they are and how people develop them and what sort of samples and examples available. They are all over the place. So we need to spread the culture of actually, Dr. Ali said, people don't usually feel the need to actually grade using the rubrics, but we need to spread the culture and show people how important in this in the issue of assessment. What do you think, Professor Hamza, if you are listening to what I'm saying?
Yeah, no, absolutely. Yeah.
Hamza.
Yes, Professor Abdulmanam. Yes, thank you very much. You brought that. People sometimes they say really, and I mean we have done many times workshops and writing the rubrics and so on. Really, they feel some difficulties, and there is a lot of culture to be really, and even the feedback. If you look at just a simple feedback, people are giving feedback and so on. But the feedback, it is a just one-way feedback and just telling what you have done, what you have not. You will see that some senior people, they're doing like that. So now it is very, very clear that your exam, your assessment should be very robust. It is not just to nowadays, and I mean, or any college, and I can say at least in Saudi Arabia, the student, they're looking for marks. They say, why you have given me 9.5? Why you not given 10? They don't say that what I missed, but they say you should give me 10 and so on, because our system. So there's a lot of things really to be, and I mean, created and make the culture of using rubrics, giving feedback, no marks. You should receive our student. They don't like to receive feedback without any giving any marks and so on. So we make something very small amount of that. Yes, okay, this session is only you attend and you get the feedback and you get out of 100 only 1 mark or something like that. So there's a lot of things, Professor Abdulmun'im, and I totally agree with you that especially in assessment we have to assess. See how huge work they are doing it, how extensive work. Just before that, we have already attended with Professor Case Bulletin that we have to collect the many data from the longitudinal, out you're taking, Dr. Ahmed, longitudinal data to say that at the end that our candidate is competent. It's not just giving the marks and they say that you got above 90, because usually students, they're looking for above 90%, 95% to get A or A plus, because they are going to be accepted in the postgraduate. So there's a lot of system has to be changed and has to be really created there. Thank you very much.
Yeah, no, these are excellent comments. And, you know, for me, I think it's culture, like you said. Like when I was in Egypt in school, I would get a 97. My mom will kill me. Zay تجيب 97 best, you know, and they're like, what? But here in the US is different. There isn't the competition where I just have to be number 1. It's more of, you know, it's built in from first grade. It's like my daughter's in school here, and there's no rank, there's no grade. It's about, do you understand or not? You know, and that's the emphasis. And you know, it's cultural, as you said. Absolutely.
But I think Hamza and Ahmed, at this point in time, if we spread the culture of using rubrics, then even the students who come and argue, you already given them the rubric and they know why they got 9 and not 10, because according to the rubric, you are here.
Yeah.
I totally agree with you, Prof. I totally agree with you. But these are things, as you said, that really needs a lot of creation, changes of. I can just give you one small example that in one of the clinical rotation, I don't remember, that he failed in OSCE and he passed in other exams, and he got above 60%. And they fail him because you core clinical competencies you fail, and university refused. They say no, he will pass because he got the 60 marks. That's all.
You know, that's a great point. So here we developed something called a portfolio. Do you guys use portfolio?
Yeah, we very small scale. We are using it, but not that. And I mean the holistic from the first year to final year. Yeah.
Yeah. So portfolio essentially is you take all the didactic in a clinic, and in the rubric, it's very defined. You have to pass everything. If you pass only the OSCE, but you fail the clinic, you fail. And these are part of the rubric. At the beginning of the year, they get it. So there's no argument, you know.
Any other question? Yeah,
Dr.
any other
Shadia,
comment?
we suggest you that the next session should be about the rubric, as Professor Abman, I'm suggesting that.
Sure,
Yeah,
sure.
we could do
I have
that.
noted it.
I would like to invite one of my colleagues on the medical side to actually come and do that session with me. You know, he's more knowledgeable in the medical side. I think it'll be more applicable for you guys.
Great.
So let me
great.
reach out and see what we can do.
Great. Shazia will
Okay.
contact with you, I think.
Thank you.
Yeah, sure. I have noted, and hopefully we shall do. There is one question by Dr. Mohammed. Thank you, Dr. Ahmed, for this session. What are your suggestions regarding promoting a greater emphasis on conceptual learning as opposed to rote learning?
As opposed to what again?
Rote learning, memorizing.
Okay. Yeah. I mean, it just goes back to don't make your grades like the more weight is placed on clinical practice. So for example, in our courses, they have a multiple choice exam, but the multiple choice exam is only worth like 5%. You know, it's more about clinical application. The clinical application is a big part of it. So if you continue to reward them more for, you know, multiple choice and, you know, whatever test, then that's all they're going to care about. We also have an issue with professors repeating questions every year. It's the same question. When I was in Egypt, they tell me, if you've memorized this book, all the questions are from the book. You have to change the questions and make it more system-based clinical questions. And that's where it is now. You know, not to see if they know, it's can they apply the information.
Yeah, agreed. Thank you, Dr. Ahmed. There is one request from Dr. Highland that could you please type your email in chat box for access? Yeah.
Let's do that right now. Where's the chat? Right there, chat. Okay.
If there are any questions from participants before we end session.
Here we go. I just wanted to thank you guys. Thank you so much for, you know, your for attending and your interest, and it was great to meet everyone. I'm glad to see that that, you know, Saudi Arabia is advanced, way more advanced than Egypt for sure, and the rest of the Middle Eastern countries in assessment, education, and all that. I think you guys are experts. I'm impressed with the level of knowledge of everyone, and again, thank you, and I look forward to interacting with you guys and hopefully being in Saudi Arabia for one day and visit.
Hopefully. Thank you so much, Dr. Ahmed Sabbah. It is really a wonderful session with you, and on behalf of SESME, I would like to say again thank you, and would hope to see you again in some other session, and we shall continue this collaboration. Now I think this is the time to apply all of this whatsoever we have learned, and we need a lot of faculty development.
Yeah.
So thank you very much, participants. Hope to see you in next session. Thank you very much. So I'm going to close session.
Okay.
Bye-bye. Have a good night.
Bye. Good night.